From the E.N.T and head and neck surgery department. We will be presenting an interesting case of Castleman disease. Uh, we have chosen this case because number one is not so common. Number two, the etiology is again it is diagnosis of exclusion, and because of the rarity, the treatment is not very standard. And also, we thought instead of taking core ENT, better to take the subject where the other department can also participate. So well, I'll request Dr. Nisha, our SR, to start case, please.
Would like to welcome all the faculty members and the residents from the different departments who will be participating with us. Starting with the case presentation, a 14-year-old girl presented with chief complaints of neck swelling for the past 4 years. To start with, it was small swelling which started on the right side 4 years ago. It rapidly progressed during the first year to involve both sides of the neck. It progressed more gradually for the next 1 year and then remained stable for the next 1 to 2 years. There was no history of pain, redness, pus discharge from the swelling. There was no history of nasal obstruction, discharge, or cough. History of snoring was present, and no history of mouth breathing was present. Aphasia, dyspnea, dysphonia. There was no history of headache, fever, night sweats. No history of abdominal pain, swelling, or swelling in other parts of the body. No history of significant weight loss. No history of skin rashes, joint pains, and no other systemic complaints. Past history, no comorbidities, no documented drug allergies. She had no history of blood transfusion or any previous major surgery. She had a history of FNAC, and biopsy done from the neck outside. There was no history of previous prolonged hospital stay. Family history, there was no history of chronic disease or similar complaints in the other family members. No history of tuberculosis in the family. Personal history, she's a resident of Sundarban, West Bengal. She's a 9th class student. She has normal bowel bladder habits, normal sleep and appetite, and menstrual cycles are regular. On examination, she was conscious, oriented, and comfortable to time, place, and person. Her pulse rate was 92 per minute and blood pressure 128 by 72 mm of mercury in the right upper arm in the sitting position. Saturation was 100% room air. There was no stridor, no pallor, icterus, clubbing, cyanosis, and pedal edema. Rest of the examination was within normal limits. Local examination. On inspection, bilateral multilobulated swelling in the anterior and lateral neck was present. Largest 6 cross 5 centimeter bilaterally, level 2, 3, and 4. Superiorly, the swelling was extending to the lower border of mandible and inferiorly till clavicle and sternal notch bilaterally. And posteriorly, it is going to the nape of the neck. A well-healed scar could be seen on the right side neck swelling. This was secondary to the history of biopsy procedure. There's no signs of inflammation. Skin was smooth. There were no dilated veins and no visible pulsation seen. On palpation, the swelling was non-tender. There was no local rise of temperature. It was multiple, firm, discrete ovoid swellings, not fixed to the underlying and overlying structures. The swelling was non-compressible, non-fluctuant, non-pulsatile. There was no palpable thrill, and trans-emulation test was negative. The trachea and the laryngeal framework was palpable in the lower neck. The suprasternal notch was normal. The sternum percussion was resonant. On examination of the oral cavity, there was bilateral grade 3 tonsil hypertrophy present. Rest of the subsides were within normal limits. Nose, bilateral patent nasal cavities. Diagnostic nasal endoscopy showed grade 2 adenoid hypertrophy, and bilateral fossa of Rosenmuller was normal. Ear examination, bilateral pinna in EAC was normal. Bilateral tympanic membrane normal. Bilateral Renes was positive and it was centralized Weber. Eye examination, vision was grossly normal. There was no restriction of eye movements. On fiber optic laryngoscopy, endolarynx is normal and bilateral cords mobile. The patient had already underwent a battery of investigations outside. In 2018, when the swelling started, patient had underwent an ultrasound neck, which shows bilateral multiple cervical and large lymph nodes, the largest on the right side being 16 to 27 mm, and the largest on the left side being 25 to 22 mm. The FNAC showed granulomatous lymphadenitis, suspected TB. MEN2 was negative, chest X-ray was within normal limits. No ATT was started in view of lack of evidence, and the patient was kept on follow-up. However, patient underwent a repeat ultrasound neck in 2019 in view of progressive swelling. The ultrasound showed a progressive increase in the size of the swelling, largest on the right side being 54 into 31 mm and largest on the left side being 38 into 44 mm. The FNAC showed chronic lymphoproliferative disorder. Patient also underwent a biopsy this time, which showed Castleman's disease, hyaline vascular type. The ultrasound abdomen was suggestive of mild hepatosplenomegaly with cholelithiasis. After this, the patient has reported to AIIMS Delhi in 2022 after the stabilization of COVID infection. Coming to the radiology part, it will be discussed by Dr. Lokesh.
So CCT scan of this patient was done. Contrast enhanced scan of the neck of this patient was done. There were 2 time point scans of the same patient. So this is the axial images. We can see there are multiple enlarged bilateral symmetrical hyper enhancing nodes as compared to the muscle. These are hyper enhancing, and there is involving all the levels. Level 1 to 5 levels are involved. Also, there is associated enlargement of the bilateral lingual tonsils, which is causing mild narrowing of the oropharynx. And apart from that, there was the IJV and on the left side was not visualized, likely due to the compression of the mass effect by the these lymph nodes. So the characteristic imaging appearance in this was the hyper enhancing, enlarged, bulky, bilateral symmetrical nodes which were homogeneous and they were hyper enhancing. And this is the coronal images, coronal CCT images of the same, which shows the same pattern, bilateral cervical nodes which are involving all the cervical region. So our differentials based on the imaging included first would be Castleman disease, then granulomatous infection like tuberculosis or histoplasma usually show a necrotic lymphadenopathy, but can have some soft calcifications. And a treated lymphoma also show enlarged nodes and sometimes they can be hyper enhancing. Kimura disease also shows a painless lymphadenopathy and there are bilateral enlarged nodes and metastasis from likely a papillary cancer of thyroid or other can have a hyper enhancing nodes. So I think biopsy was done with this patient, but Dr. Nisha will take over.
The patient underwent right side cervical lymph node biopsy under local anesthesia at AIIMS, and there were no intra-op and immediate post-op complications. For the biopsy part, I'll be calling upon Dr. Soumya Sahu.
Good afternoon, everyone. So this was the gross photograph of the right cervical lymph node, which is showing enlarged lymph nodes and the cut surface was formed. So section examined shows there was effacement of nodal architecture with marked expansion of interfollicular area, and we can appreciate here the thickened sclerotic vessel. So these are the follicles with thickened mantle zone formed by lymphocytes giving a onion skin appearance, and this is the sclerotic vessel, and this is the center of the follicle which is replaced by dysplastic follicular cells. So again, this is the high power pictures to show the dysplastic follicular dendritic cells. There was some plasma cells which were positive for kappa and few were positive for lambda also, and TTT was also done. Sorry, the pictures cannot be incorporated due to some technical issue. So TDT showed positivity in the interfollicular area, and we also done HHV8 immunostain, which was negative. So the diagnosis was given as Castleman disease, mixed variant. From the same patient, we also received FNA from the submental lymph node, which showed reactive lymphoid cells. However, no excess of plasma cells noted. Again, there was a left cervical lymph node of the same patient and showed similar histological features. There was also a sample from the thyroid lobe, which showed enlarged thyroid follicles with the evidence of fresh and old hemorrhages. So the diagnosis was given as hyperplastic nodule in thyroid and left and right cervical lymph node, Castleman disease mixed variant. However, with the positivity of TDT, the differential was indolent lymphoblastic lymphoma was also kept. Thank you.
Coming to the current classification of Castleman's disease, it can be broadly classified into two types, unicentric and multicentric Castleman disease. The multicentric can be further classified as associated with Poems syndrome, which is polyneuropathy, organomegaly, endocrinopathy, M protein changes, and skin changes. Also, it can have associations with HHV8 virus, which can have further association with HIV. So after ruling out the Poems and HHV8 association, and also after excluding other diseases like autoimmune disease, SLE, rheumatoid arthritis, malignant diseases like lymphoma, and infections like TB, we can make a diagnosis of idiopathic multicentric Castleman disease. It can be further classified as Staphylos syndrome, which is a more clinically aggressive form and not otherwise specified is the other subset. So we reviewed all the blood investigations of this patient, which were done outside, and also got the fresh investigation done at AIIMS. So the only abnormality we found in our patient was the raised ESR, which was 30 outside, and at our lab it was 53. So to rule out other causes of other to rule out multicentric Castleman disease and other causes, we have done further investigation. The peripheral smear was done. We showed RBCs as normocytic and normochromic. WBC showed neutrophilic predominance. There were no circulating plasma cells and platelets were adequate. The ESR was raised and CRP was 2.9, which is also raised. Procal was 1.98 nanogram per ml. LDH, autoimmune markers, and coagulation profile was within normal limits. Thyroid profile and viral markers were negative. HbA1c was within normal limits. Also, we got serum interleukin 6, which was 5.3 within normal limits. We also got ultrasound abdomen, which was normal, which showed normal study. Chest X-ray was normal. The PET CT showed multiple discrete and conglomerated FDG avid bilateral cervical 1 to 5 lymph nodes of various sizes. The largest in the left, level 2, around 3.5 to 2.5 centimeter. Urine and serum M-band electrophoresis showed no M-band and normal polyclonal gamma globulin was present. Bone marrow aspiration biopsy showed tri-lineage hematopoiesis. So diagnosis of unicentric Castleman disease was made. Now the further thing was to evaluate for the resectability. Since the disease was involving only the neck, the disease was very well resectable. So we underwent with the surgery. Patient underwent bilateral neck dissection, right side modified neck dissection 3 and left side modified neck dissection 2 in October 2022. Intra findings, there were multiple conglomerated nodal masses involving level 1 to 5, largest in the left level 2, 10 into 6 centimeter. There were no extranodal extension. There were dense adhesions noted in the posterior triangle around the carotid sheath. This is the intra pics showing the left side neck dissection. Also, we can see the resected specimen, the smallest being 3 into 2 centimeter and the largest being 10 into 6 centimeter. This is the post-operative histopathology, which was suggestive of Castleman's mixed variant, already discussed by Dr. Soumya. Coming to the follow-up, this picture is showing the 1-year follow-up of this patient. Currently, the patient is asymptomatic. Comparing the pre and post-operative inflammatory markers, we can see that there is a decreasing trend of the ESR. For the urological.
follow-up CCT scan of neck of this patient showed some residual hyperenhancing submental and submandibular nodes, and there was mild sublingual, the tonsillar shows some enlargement. Apart from that, there is significant reduction or post because of the surgery, the reduction in the cervical lymphadenopathy. It's the coronal image showing the same findings.
Castleman disease is a rare known non-clonal lymphoproliferative disorder having distinct subtypes depending on its etiology, pathology, and clinical presentation. It can affect lymph nodes of any body region, imitating both benign and malignant abnormalities in the neck, chest, abdomen, and pelvis. Clinically, it manifests as a more common unicentric Castleman disease and less common multicentric Castleman disease. The incidence of unicentric Castleman disease has been estimated to be 16 to 19 per million in the US population, which translates to 5,000 to 6,000 patients per year. The etiology and pathogenesis is secondary to the chronic low-grade inflammation, lymphoid hematomatous, hyperplasia, viral infections, abnormal moderation of cytokines, and angiogenesis. There is an impaired immunoregulation that causes abundant proliferation of B lymphocytes and plasma cells in the lymphoid organs. Interleukin-6 plays an important role in the pathological mechanisms, and the symptoms and pathology can be explained by the overproduction of IL-6. In addition, very close association of the disease with HIV and HHV8 has been discovered, which causes deregulation of the inflammatory mediators like CD20 and interleukin-6. In unicentric Castleman disease, there is single enlarged lymph node or multiple enlarged lymph nodes within a single lymph node station which are involved. It behaves in an indolent fashion and the enlargement is gradual. In multicentric Castleman disease, lymphadenopathy affects multiple lymph node stations. It is associated with systemic symptoms like fever, weight loss, fatigue, driven by interleukin-6 and other cytokines. Unicentric is more common than multicentric, and it affects younger patients, mostly in the 4th decade, with more of a female preponderance. Lymph nodes are bigger and constitutional features are lesser in unicentric, and most commonly involves the mediastinum, followed by neck, abdomen, retroperitoneum nodes. There is no risk factors of genetic predisposition. Both unicentric and multicentric Castleman disease can progress to lymphoma. It's more common in the multicentric Castleman disease. It's important to consider the location and resectability of the enlarged lymph node before taking the patient for surgery, and the degree to which they cause symptoms by compressing the neighboring anatomy and inducing in systemic inflammatory syndrome. If it is resectable, then complete surgical excision should be done. And if it's unresectable, like if it's because of its size and location, then in that case, if it's asymptomatic, wait and watch approach can be adopted, especially when there's a normal laboratory values who are also when they're asymptomatic and unlikely to develop future symptoms. Regular CT scan can be done at 12-month intervals, as well as annual physical examination and laboratory investigations can be done. If they have symptoms related to compression and inflammation, so when they have compression-related symptoms, partial resection can be done to debulk the disease. Also, they can be rendered amenable to surgery through medical therapy with rituximab and with or without steroids. There's also a role of pre-surgical embolization in large vascular unicentric lymph nodes to render them safe for surgery. Also, when the patients have inflammation-related symptoms like fever, weight loss, and when they have blood abnormalities like increased ESR, CRP, in that case, anti-IL-6 agents like cetuximab or tocilizumab can be used. Patients who have unresectable disease after medical therapy but are rendered asymptomatic can be observed. Despite therapies directed at compression-related symptoms and inflammation-related symptoms, if the patient is still symptomatic, then they are candidates for radiotherapy. So this is a treatment logarithm as already discussed. Prognosis and follow-up, as per the studies by Dispensary and Talat et al., the 5-year overall survival and 10-year overall survival for the unicentric Castleman disease treated with surgery has been 91%, 95% respectively. For our patient, we have done, for the follow-up, we have done repeat CT scan after 3 months and also done clinical examination. And currently, the patient is asymptomatic and is on regular follow-up. We are now doing yearly ultrasound neck and blood tests like CBC and ESR. I would now like to invite Dr. Poonam Sagar for the further discussion.
Thank you, Dr. Nisha. Good afternoon, all. So, as said that we wanted to discuss a multidisciplinary approach case. So, Castleman disease, one aspect is of the unicentric Castleman disease. For that, the treatment of choice is surgery, and the other aspect is the multicentric disease. For those, all the systemic features and the multicentricity and the disease in the whole of the body needs to be ruled out. Another aspect from the case presentation is that the patient wanted cosmetic correction due to the increased swelling in the neck. So for that case, the simple surgical resection was done of the bilateral lymph nodes, and the patient is satisfied with this treatment. The main aspect is that the Castleman disease, it was initially described as a benign lymphoproliferative disorder, but as we have seen that multicentric disease, it is associated with human herpes virus infection, which is also known to cause Kaposi sarcoma, and the HIV related disease also it is associated. So lymphomas like the Hodgkin's lymphoma and other malignancy needs to rule out in this case. The surgery provides specimen to for detailed analysis also. In this, there was a huge specimen. So in that case, the few malignant or the abnormal B lymphocyte or other things can be found out as told out by our pathology colleagues. Thank you. Any questions?
I think we have the one of the largest series published from AIIMS. We should shown up the data. It is a 50 cases of Castleman diseases from AIIMS data. And another interesting case was published from our department again with medical oncology, Castleman disease with the Hodgkin lymphoma, which is very missed commonly. So this data could have been incorporated. So how much cases we are receiving at our institute? That could have been interesting.
So,
that is one of the largest series in the world, 50 cases. Second thing is you showed that is a treated lymphoma. I couldn't understand why the differential is a treated lymphoma.
so that is a radiological differential was there.
I said, no, but it is such a huge mass. That's only my query. Each treated lymphoma can present as a mass. It looks like it's so scary.
Yes, sir, but the differential we have kept like a hyper enhancing lymph nodes or hyper attenuating lymph nodes.
Is it all the nodes shows like a calcification? If I think I think that we have kept in the fourth Rosae-Duffman disease. We have kept as a differential diagnosis, Rosae-Duffman. Because classically,
Yes.
Sir, Rosai Hoffman or which disease, sir?
Rosae-Duffman versus Castleman disease.
The Rosai Hoffman will have sinus involvement also. Because sinus involvement will be there.
And this particular case is TDT is positive. We don't want to confuse too much. This is a new terminology new things. Nobody knows what is the significance. Indolent lymphoblastic lymphoma.
Yes.
That classically lymphoblastic lymphoma is the aggressive tumor. But recently, this first the MD Anderson group published a set of cases. Accidentally, they found out TDT is positive in case of Castleman, but nobody knows whether there's progress to lymphoblastic lymphoma or not. But just mere presence of TDT not make, just to highlight mere presence of TDT, not make a case to lymphoblastic. This case is very nicely shows a focal TDT positivity, which is now is very called indolent lymphoblastic lymphoma.
Yes, sir. Because of that point only, the patient needs follow-up for the long.
No, there's no data to suggest that ILBL is progress to lymphoblastic lymphoma. That's just an incidental finding, but how to interpret the data and how to treat, nobody knows. This is just, this time WHO introduced as a interest, this is a precursor lesions, but prognosis, treatment, is nobody knows. I think hematology, sir, is Mahapatra sir, is, they can say if there is indolent lymphoblastic lymphoma, how to go ahead.
I don't know the mechanism, but it's a good marker for the to differentiate from the mimickers. Castleman is a very non-specific. Many times it's a are misdiagnosed as Castleman. So it's a good for the TDT positivity is good for the to differentiate from the mimicker. I don't know the relation, but it is commonly seen in the common.
Two aspects of this. It's a TDT.
So TDT was possible.
Roj,
Suppose it's some other case. In those cases, I think there is a point to do TDT maps.
no, sir, Castleman plasma cell variant is always a diagnosis of exclusion. Just mere presence of plasma cells cannot make a case of Castleman. But this case, like a typical this onion type of appearance and sclerosis, hyaline vascular is very specific for a Castleman, but plasma cell variant needs a lots of workup to rule out whether it is a Castleman or mimickers. And the mixed variant is most common, as we see in this case. There's a hyaline vascular plus plasma cell. So it's a mixed variant of Castleman. So another query is whether it is a unicentric or multicentric, because there are multiple nodes. So how to things. Ma'am, operated, I think only 7 cases was operated. Only 7 cases was operated for biopsy for all. Ma'am was asking operated. Resection, ma'am, only those cases was a huge single unicentric large mass they operated, not all the cases. They mostly managed by other modes of treatment. There is no standardized treatment, but I think now idiopathic treatment, Castleman disease, they have a IL-6 inhibitor which came 2 years back as the standard care. Dr. Rishi can.
So I had a couple of comments regarding the discussion that was happening. So as far as the pathology part is concerned, and if you see the discussion of multicentric Castlemans, so the overlap with autoimmune disease is a very, very significant pattern that we need to recognize. So not so relevant for unicentric Castleman, but very relevant for multicentric Castleman. Yes, sir. Yes, sir. Yes, sir. Yes, sir. So the presentation with autoimmunity. So even multicentric Castleman can present with autoimmunity. Diseases like lupus, RA, even myositis may present with a Castleman-like morphology on the lymph node with autoimmune features, and the two may also coexist. So we have around 4 patients on follow-up where we tried to make that distinction, and we did find that there were a genuine overlap with the underlying autoimmune disease and Castleman's going along hand in hand. So that is as far as the histopathology is concerned. And as Soumya sir is saying, that differentiating from hyaline vascular and the plasma cell variant helps us in a significant way. As far as IL-6 therapy is concerned, so that starts, so IL-6 is the dominant pathogenic cytokine in these patients, which drives the hyperinflammation, which is more common in the multicentric patients. So siltuximab forms the first line therapy if you look at the guidelines, but availability etc becomes an issue. So we have tocilizumab, that is so class 1 evidence for siltuximab, maybe class 2A for tocilizumab, which has the costs are coming down because of increasing use in autoimmune diseases. So that is one. But even when the patient cannot afford that, we have had relatively good responses with rituximab as well, especially for the ones where the hyperinflammatory profile is not as dominant. So there is some lymphoproliferation, but the hyperinflammation which is being guided by the IL-6, maybe if that's not very high, even rituximab does show good responses. I think that was my two comments on what was being discussed.
Thank you.